Let's talk a little bit about what is belzutifan. So belzutifan is a HIF-2 alpha inhibitor. And HIF-2 alpha is important because the von Hippel-Lindau syndrome, or VHL, is upstream of HIF-2 alpha, and it's essentially considered a tumor suppressor gene. Now, not everybody has the von Hippel-Lindau syndrome or VHL syndrome, where you get like pheochromocytomas, hemangioblastomas, and clear cell renal cell carcinoma. But that area of the chromosome that VHL is located on is probably deleted or lost in about 91% of patients with clear cell renal cell carcinoma. So you might not have the inherited autosomal dominant genetic syndrome, but it is generally that area is lost in patients who have clear cell renal cell carcinoma in their tumor, okay? Hence, that makes this target a good target for most patients with clear cell renal cell carcinoma. And as a HIF-2 alpha inhibitor, it's generally thought that it's a transcription factor and is hypoxia inducible. It's been thought that transcription factors generally are not good targets for drug or druggability, but they did find this pocket that interacts with binding to DNA that actually you can slip a drug into. And there are other HIF-2 alpha inhibitors, but belzutifan obviously is the one that's FDA approved for VHL syndrome and has gotten a lot of attention here for clear cell renal cell carcinoma. So let's talk about that data. The most exciting recent data presented at ESMO 2023 was that LightSpark data that showed in the second to fourth line in patients who had received prior immune-oncologic treatment and also VEGF receptor TKI therapy, that in the second to fourth line that there was significant progression-free survival benefit compared to everolimus as the control. Now, don't be fooled by the median progression-free survival, which was around, I think, 5.6 months for both belzutifan and for everolimus. That's because the curves kind of crossed a little bit, but essentially were similar all the way down to the median 50th percentile, and then they split dramatically in favor of belzutifan. Why? Because it's a different mechanism of action than what we use for renal cell carcinoma. We're using TKIs, which induce a lot of responses. We're using IO, which causes a nice tail at the end of the curve and long-term durability for those who respond. But belzutifan's a different agent. It does not induce rapid responses. What you see with belzutifan is that over time you get deeper and deeper responses. So you get patients who might get their partial response months after they start therapy, and then they might get a complete response even more months later. So you get better and better responses later for those who are going to respond. And that's why the medians are kind of the same, and you get your split in the curves later. But the hazard ratio is formulated by the difference between the two curves, the area between those two curves, and it's clearly in favor of belzutifan. Now, most of the patients, over 80%, were late line therapy, not second line, but really third or fourth line. And that's probably where we'll see regulatory approval. But you asked the question, what's next for belzutifan? What about first line or earlier therapy? Well, here's the thing. In kidney cancer, I just told you that the TKIs give you the quick response. So if you have a symptomatic or really bulky patient, that's important. The IO gives you the tail on the end of the curve. So when you look at belzutifan, more data that was presented at ESMO was with cabozantinib, and they looked at it in first line and in second line and beyond. And in second line and beyond, I believe it was in the 30% range response rate. But in first line with cabozantinib, it was 70+%. Pretty good. But the thing that's missing there is the IO, because that's where you get the tail on the end of the curve. And so there is an ongoing randomized controlled trial that looks at pembrolizumab, your IO, lenvatinib, your TKI, and belzutifan in that first line setting. And of course, we'll have to wait to see the data, but that may be the promise to get belzutifan into earlier disease states. That said, I think the next step for regulatory approval is probably for late line, third, fourth line therapy for belzutifan to become the next standard of care there.